Welcome back to the deep dive. Today isn't just a casual exploration. We are entering the war room. We're simulating a really high-stakes study session. I want you to imagine the clock is ticking, the coffee is cold, and the Gujarat University MD anesthesiology exams are just looming on the horizon.
It's a familiar feeling for many. I remember it well. The pressure to not just know the clinical work, but to somehow translate all of that into a 20-mark answer sheet and then, survive the firing line of a viva voce.
Exactly. And today, I'm the postgraduate student, probably a little panicked, staring at this mountain of books. And you are playing the role of the senior MD anesthesia faculty. Our mission, to crack the topic of total intravenous anesthesia, or CRAVNS.
Right.
We aren't just chatting. We are digging through Miller's 10th edition Morgan and Mikhail Stolting's Pharmacology. And, of course, those exam-specific lifesavers, like the Kaushik-Jathanath Review and the DNB Question Bank.
An excellent stack of resources. And TIVA is a topic that, well, it really separates the novices from the experts. It requires profound understanding of pharmacology. It's not something you can just wing in an exam.
Okay, well, let's start with the basics then, to sort of get the ball rolling. Isn't TIVA just, turning on a Propofol pump and walking away?
Stop right there. That definition is exactly how you fail the Viva in the first 30 seconds. That is a classic trap.
Okay, let's unpack this. Why is that a trap?
Because if you tell an examiner TIVA is just running Propofol, you're completely ignoring the analgesic component. You're ignoring the muscle relaxation. You're describing sedation, not general anesthesia.
I see.
The strict exam-approved definition, and you'll find this in Kaushik-Jathanath in practically every standard text, is that TIVA is a technique of inducing and maintaining general anesthesia using exclusively intravenous agents.
Exclusively? So absolutely no inhalational agents?
None. Zero. And that includes nitrous oxide. This is a common mistake. If you have that nitrous rotameter open, even just a little, it is not TIVA. It becomes balanced anesthesia.
Okay.
In TIVA, we are relying on the independent titration of our hypnotic and our analgesic, and we're doing it without the safety net of measuring end-tidal gas concentrations.
That's a crucial distinction. In gas anesthesia, we have Mackie minimum alveolar concentration to guide us. We know what's going in and what's coming out. With TIVA, we're kind of flying on instruments, or rather on pharmacokinetic models.
Precisely. And that brings us to the rationale. Why bother? Why not just use sevoflurane for everything? The exam answer needs to highlight specific indications. We do it for a better recovery profile, that famous clear-headed wake-up.
Right, less post-op grogginess.
We also do it for very specific patient indications, like malignant hyperthermia susceptibility, where volatiles are absolute lethal triggers, and increasingly we do it for environmental reasons.
The green anesthesia angle. I've seen that popping up in a lot of recent papers.
It's huge. Volatiles are potent greenhouse gases. TIVA basically eliminates that part of our footprint. But let's get practical and look at the exam paper itself. If you get a long question, say for 20 marks, it usually reads something like, describe the principles, drugs, delivery systems, and monitoring of TIVA.
Right, the whole package. But we also see short notes, right? Things like target-controlled infusion or context-sensitive halftime.
Or propofol infusion syndrome, exactly. And in the Viva, they'll hit you with practical things. Why did you use TIVA for this spine surgery? Or can you please draw the 3-compartment model for me?
Let's get into the meat of it then. Section 2 of our outline, basic principles. You mentioned earlier that TIVA relies on independent titration.
Yes. Think of the triad of anesthesia. In the old days, or even with high-dose volatiles, one drug, the gas, did a lot of the heavy lifting. It provided hypnosis, some analgesia, and it potentiated immobility. TIVA is different. We are deconstructing the soup.
So we use specific ingredients for specific tastes, a more a la carte approach.
Exactly, a perfect analogy. We use a specific drug for hypnosis, usually acting on GABA receptors, like Propofol. We use a specific drug for analgesia, acting on mu receptors, like Remifentanil or Fentanyl. And then we use a specific drug for immobility, the muscle relaxant.
And the advantage is you can tweak one without messing up the others.
Precisely. If the blood pressure drops, I can lower the hypnotic, the Propofol, without compromising the pain relief from the Remifentanil. It's a much more elegant control system.
But here's the challenge, and I think this is where it gets really interesting for you, the learner. With gas, we measure the end-tidal concentration, which closely mirrors the brain concentration. With TIVA, we're just pushing drugs into a vein. How do we have any idea what's actually happening in the brain?
That is the core conflict of TIVA, plasma concentration versus effect site concentration. We can easily estimate the concentration in the blood, the plasma, but the patient doesn't go to sleep because there's propofol in their arm vein. They go to sleep when it reaches the biophase, the site of action, which is the brain and spinal cord.
And there's a delay. It's not instantaneous.
Miller calls this concept hysteresis. There is a temporal lag between the peak plasma concentration and the peak clinical effect. If you slam a bolus of fentanyl, the plasma level spikes instantly, but the patient doesn't stop breathing for a couple of minutes. Understanding that lag is absolutely vital for doing TIVA safely.
And this leads to how we deliver it. Conceptually, we have open-loop and closed-loop systems.
Conceptually, yes. Open loop is what we use 99% of the time in clinical practice. The anesthetist decides the rate. I look at the patient, I look at the monitors, and I set the pump to 100 milliliters per hour, or I set the target to 4 micrograms per ml. I am the one closing the loop.
And closed loop, is that the future?
That is the future, potentially. It's where a computer measures the EEG, the depth of anesthesia, and the computer itself adjusts the pump rate automatically. Think of it like the autopilot on a plane. But for your exam, and this is important, remember, most commercial TCI pumps are technically open loop because you select the target, not the patient's brainwaves.
Okay, that's a key distinction. Now let's dive into the scary part for a lot of students. The math. The pharmacokinetic basis. If I'm writing that 20-mark answer, I absolutely have to talk about compartment models.
You cannot escape the compartments. To score high, you have to show the examiner you visualize the body not as a single bucket, but as a series of connected tanks.
So unpack the 3-compartment model for us.
Okay, imagine 3 tanks or boxes connected by pipes. The central tank, we call it V1, is the blood and the highly perfused organs, the heart, brain, kidneys, liver. This is where we inject the drug first.
Right. V1 is the main highway.
Connected to V1 are 2 peripheral tanks. V2 is the rapidly equilibrating compartment. This is mostly your muscle group. And V3 is the slowly equilibrating compartment. That's your fat, your vessel poor tissues.
So the drug goes into V1, does its job at the brain, but then immediately starts leaking out into V2 and V3.
Exactly. And at the same time, it's also leaking out down the drain. That's elimination or clearance, usually by the liver. The movement between these tanks is governed by rate constants, which we denote with the letter K. So K12 is the rate of movement from the central compartment to compartment 2. K21 is the return trip.
And the examiner wants to see a diagram of this.
It is mandatory. It's easy marks. You draw a central box for V1, 2 side boxes for V2 and V3, and arrows going back and forth with the K values labeled. It shows you understand that when you turn off the infusion, the drug doesn't just vanish. It starts leaking back from the muscles and the fat into the blood, which keeps the concentration up for a while.
Which brings us to perhaps the most famous graph in all of anesthesia, the context-sensitive halftime graph.
Ah, the Hughes and Glass graph, yes. This is extremely high yield.
Let's define it first, because it's not the same as a simple half-life.
No, absolutely not. Elimination half-life, or $2, is a concept for single doses. It is almost useless for infusions. Context-sensitive half-time, or CSHT, is the time required for the plasma drug concentration to decline by 50% after stopping an infusion that was designed to maintain a steady state.
And the context is the key word here. It means the duration of the infusion.
Precisely. If I run a fentanyl infusion for 1 hour, the CSHT is pretty short. If I run that same infusion for 8 hours, the CSHT is massive. The graph shows a line for fentanyl just shooting straight up into the corner of the page.
And why does fentanyl do that?
Because it is incredibly lipid soluble. After a long infusion, your fat stores, your V3 compartment, are completely saturated with it. When you turn off the pump, that huge reservoir of drug just floods back into the central circulation, keeping the patient asleep for hours. The drug has nowhere else to go.
And then there's the line for Remifentanil on that same graph.
The beautiful flat line. It stays down at around 3 to 5 minutes, whether the infusion ran for 10 minutes or 10 hours. It is context independent.
Because it's metabolized by esterases right in the blood. Correct?
Yes.
It doesn't depend on the liver or redistribution.
Correct. And that is what makes Remifentanil the almost ideal TIVA opioid. And then you have Propofol, which is somewhere in the middle. Its line rises, but not nearly as drastically as fentanyl's.
Before we leave kinetics, can you briefly touch on Kia? It sounds complicated.
It's just the last piece of the puzzle. Kia is the rate constant of equilibration between the plasma and the effect site, the brain. Think of it as the speed limit for crossing the blood-brain barrier. A high K means the drug moves fast. Remifentanil and alfentanil have a high fast on, fast off. Fentanyl has a low KIR. It takes its time. This dictates how you time your induction dose and when you expect to see the peak effect.
Okay, we've laid the foundation. That makes sense. Let's talk about the actual weapons in our arsenal. Section 4, drugs used in TIVA.
We can divide them neatly into hypnotics, opioids, and adjuncts.
Starting with the king of TIVA, Propofol.
Propofol is what enabled modern TIVA. Before propofol, we had things like thiopentone infusions, but thiopentone hangs over like a bad cloud because of its massive accumulation. Propofol has a short initial distribution half-life, maybe 2 to 8 minutes, and crucially, its metabolic clearance is actually faster than the blood flow to the liver.
What does that mean exactly? Faster than hepatic blood flow?
It means the liver is incredibly efficient at clearing it, but also that there must be some extra hepatic metabolism going on, likely in the lungs and kidneys. This high clearance is what creates that clean-headed recovery that Morgan and Mickle talks about.
And mechanistically, for the exam, it's GABA A modulation. We should probably mention the formulation issues, too.
Yes, good point. It's a 1% lipid emulsion egg, lecithin, and soybean oil. 2 critical exam points here. 1, it supports bacterial growth like a petri dish, so you must use strict aseptic technique and use it quickly once it's opened. 2, it has calories, about 1.1 kcal per ml. If a patient is in the ICU on propofol for a week, you have to account for that in their nutrition or they'll get hypertriglyceridemia.
Okay. Moving to opioids. We already praised Remifentanil.
Remifentanil is just unique. It's an estrus metabolized opioid. It's a game changer. It allows us to run a very high-dose opioid technique, giving profound analgesia, 0 response to surgical stimulus, and yet the patient can be awake and breathing within minutes of stopping the pump.
But what if you don't have Remi? It can be expensive. Can you use fentanyl?
You can, and we do it all the time in settings where Remi isn't available, but you have to be smarter about it. You can't just run a high continuous rate for hours. You have to titrate it down early, anticipate the accumulation, or the patient will be on a ventilator in the recovery room long after the surgery is over.
And what about adjuncts? I'm seeing more and more about dexmedetomidine being used.
Dexmedetomidine is an alpha-2 agonist. It's a great drug. It provides sedation and analgesia, but it spares respiration, which is a big plus. The new Miller edition even mentions that TCI models for dexmedetomidine, like the Hanover-Collin model, are now emerging. It's a fantastic adjunct to reduce your propofol and opioid requirements.
And ketamine. I see that used in low doses.
Yes, very low doses. We're talking 0.1 to 0.2 milligrams per kilogram per hour. We use it not for anesthesia itself, but to prevent a phenomenon called opioid-induced hyperalgesia. It blocks the NMDA receptor. It's a very sophisticated but effective addition to the cocktail.
Right, so we have the drugs.
Yeah.
Now, how do we actually get them into the patient? This is Section 5, methods of administration.
We have the, let's say, rudimentary method, manual infusion.
The Bristol scheme, or the Roberts method.
Yes, the classic stepping down method. For propofol, the rule of thumb is the 10-8-6 rule. You run 10 milligrams per kilogram per hour for the first 10 minutes, then 8 for the next 10, then down to 6 for maintenance.
What's the logic behind that? Why step it down?
It's a crude attempt to mimic the pharmacokinetics. You use the high initial rate to quickly load the central compartment, V1. As V2, the muscle compartment, starts to fill up, you lower the rate to match the ongoing elimination, plus the slower transfer to V3, the fat.
But it's not perfect. It's a bit of guesswork.
Far from it. You get peaks and valleys in the plasma concentration. Valleys mean a risk of awareness. Peaks mean a risk of hypotension. It's also very labor-intensive.
Which brings us to the gold standard and a huge exam favorite.
Remo.
Target-controlled infusion, or TCI?
TCI completely changes the game. Instead of telling the pump, run at 20 milliliters per hour, you tell the pump, I want a target of 4 micrograms per ml in the blood. The pump has the pharmacokinetic model, all that complex math embedded in its computer chip. It calculates exactly how much bolus is needed and what the infusion rate should be, adjusting it every few seconds to maintain that target.
Now here is a distinction that I think confuses everyone. Plasma target, or TPDES, versus effect site target, or TUVELMA.
This goes right back to that concept of hysteresis, the lag time. If I target the plasma I CP'd out, the pump will get the blood level to 4 millimol and just hold it there. But because of the lag, the brain level rises much more slowly, so the induction is slow.
So the patient is just kind of staring at you for a few minutes while the drug crosses the blood-brain barrier.
Exactly, but if I select effect site targeting, the pump knows about the lag, it's smarter, It will purposely overshoot the plasma concentration, maybe driving it up to 8 or 10 millisichinella for a very short time, to create a huge gradient that pushes the drug into the brain much faster. Then it will pause the infusion to let the plasma drop back down as the brain catches up.
So sheet targeting means a faster induction, but you might risk a bigger drop in blood pressure because of that initial plasma spike.
Precisely. It's a trade-off. Speed versus hemodynamic stability.
And we have to mention the models. Marsh versus Schnider. This is a classic Viva question.
You must know the difference. The Marsh model is the older one. It's much simpler. It essentially only uses the patient's total body weight. It assumes that V1, the central volume, is directly proportional to weight.
So if I'm a 100-kilo bodybuilder versus a 100-kilo obese patient, Marsh treats me the same.
Exactly, which can lead to significant overdosing in obese patients. The Schnider model is more refined. It requires age, weight, height, and gender. From that, it calculates lean body mass, LBM.
So Schnider is generally safer for the elderly and for obese patients.
Yes, because Schnider adjusts for age and body composition. It knows that an 80-year-old brain is more sensitive and has a smaller central volume. Marsh tends to overdose the elderly. Schnider is much more conservative and safer in that population.
Okay, moving on to section 6. Monitoring. This is huge. In TIVA, we lose our security blanket, the end tidal agent monitoring. We are essentially flying blind when it comes to the actual drug levels.
This is what we call the black box problem. If your IV line disconnects under the surgical drapes, the pump keeps beeping happily, thinking it's infusing, but the patient is getting nothing. They wake up. You have no end tidal Propofol number on the monitor screen to warn you.
So is process EEG mandatory then?
Yeah.
Or just highly recommended?
In my personal opinion, and certainly for an exam answer, you should say it is essential. You should advocate for BIS, the bispectral index, or entropy monitoring. You want to maintain a BIS value between 40 and 60. It measures the reduction in cerebral metabolic rate. It is your only real-time window into the hypnotic effect on the brain.
What about hemodynamics, blood pressure and heart rate?
They are surrogate markers, but they are notoriously unreliable. If you've given a beta blocker or if you're using a lot of Remifentanil, the patient might have a heart rate of 50 and a perfect blood pressure. But they could be wide awake if the Propofol line has failed. You cannot rely solely on hemodynamics during TIVA. It's a trap.
And a practical tip mentioned in the sources, monitor the IV line itself. Physically look at it.
It's critical. Use a running line, a carrier fluid like saline flowing with the drug. Put a one-way anti-reflux valve in the line so blood doesn't back up and clot the cannula, and ensure the cannula insertion site is visible. Remember the mantra, no 4V, no anesthesia.
Let's talk about the why again. Section 7, advantages. Why are we doing all this complicated math and using all this tech?
Well, the biggest clinical win, day in and day out, is PONV postoperative nausea and vomiting. Propofol has intrinsic antiemetic properties. For a patient with a history of severe PONV, TIVA is often the absolute best choice.
And neurosurgery, we touched on that.
Huge advantages there. TIVA reduces cerebral blood flow, or CBF, and the cerebral metabolic rate, CMR022, in a coupled fashion. It keeps things in balance. It also maintains cerebral autoregulation better than volatiles, especially if the volatiles are used at greater than 1 MAC. And crucially, it lowers intracranial pressure, or ICP.
What about airway surgery?
Think about a rigid bronchoscopy or jet ventilation. You have a completely open airway. If you use a volatile gas, you are polluting the entire operating theater and exposing the staff. TIVA keeps the room clean and safe.
And we touched on the environment earlier.
Yes, deslorane and nitrous oxide are terrible for the ozone layer and global warming. Propofol and Remifentanil have their own carbon footprint, mostly from plastic waste and manufacturing, but it's a tiny fraction of the greenhouse gas impact of volatiles.
But it's not all sunshine and rainbows. So section 8, disadvantages.
The big one, the one that keeps us up at night, is awareness. The risk is statistically higher with TIVA than with volatile anesthesia. It's because of things like line disconnections, pump errors, or just biological variability where the model predicts sleep, but the patient happens to be resistant.
And cost. Is it more expensive?
Generally, yes. The specialized pumps, the dedicated tubing, the drugs themselves, especially Remifentanil. However, Miller's textbook argues that if you factor in faster recovery and less PONV, which means less time and fewer drugs used in the PCU, the total hospital cost might balance out.
There is also the issue of drug wastage.
Yes. Once you drop a 50 cc syringe of Propofol, If the case is canceled or finishes early, you have to throw the rest away. You can't keep it for the next patient because of that bacterial growth risk and the lipid emulsion.
Okay, let's look at some specific clinical applications in Section 9. We mentioned neuro.
Specifically, think about spine surgery with motor evoked potential, or MEP, monitoring. Volatile agents suppress MEPs. They basically turn off the electrical signal the neurologist is trying to monitor. A TIVA technique with Propofol and Remifentanil preserves these signals beautifully. So for a big scoliosis correction, TIVA is almost mandatory.
A daycare surgery.
It's perfect for it. Rapid turnover. Patients wake up clear-headed, they can drink faster, walk faster, and go home sooner with less nausea.
Remote locations, what we call NERO,
Yeah.
or non-operating room anesthesia.
Exactly. The MRI suite, the cardiac cath lab, often these places don't have proper scavenging systems for waste gas. Or the anesthesia machine itself is just too bulky to fit. A couple of syringe pumps take up very little space.
All right, Section 10, complications and pitfalls. We talked about awareness. What is PRE-S? I see that acronym a lot.
PRE-S stands for Propofol Infusion Syndrome. This is a rare but often fatal complication. It's associated with very high doses, usually greater than 4 milligrams per kilogram per hour for long durations, typically over 48 hours.
So it's more of an ICU concern than an operating room one.
Mostly, yes. But it has been reported in very long neurosurgeries or in susceptible children. It presents as a catastrophic metabolic acidosis, rhabdomyolysis, cardiac failure, and sometimes even green urine. It's a toxic effect on the mitochondria.
Another pitfall is the dead space in the IV line.
A classic rookie mistake.
Yeah.
You finish the case, the patient is waking up, and you flush the IV line with saline to take it out. And suddenly the patient stops breathing again. Why? Because that long extension tubing was full of propofol and remifentanil, and you just flushed it all into the patient as an accidental bolus. You must always aspirate back or disconnect right at the cannula.
And the concept of synergistic overdose.
Miller's textbook emphasizes this. Hypnotics and opioids are synergistic, not just additive. It's like 1 + 1 = 5, not 2. If you have a high background level of remifentanil, you need very, very little propofol. If you run both at high rates, you will cause profound hemodynamic collapse.
Okay. Section 11 is comparison with inhalational anesthesia. This is a very likely table you'll be asked to draw in the exam. Let's just run through the main rows.
Okay. Row 1, induction. TIVA is generally smoother and faster, though sevoflurane gas induction in children is a close rival. Row 2, maintenance. TIVA needs pumps and electricity. Gas needs a vaporizer and a fresh gas source. Row 3, monitoring. This is a big one. Gas has real-time feedback with end tidal monitoring. TIVA relies on predictive models and ideally processed EEG.
What about organ protection? I've heard volatiles protect the heart.
That's a good point for the volatiles column. They have a phenomenon called ischemic preconditioning. They seem to offer some protection to the heart muscle against ischemia. TIVA does not appear to have this effect.
And HPV, hypoxic pulmonary vasoconstriction. This is important for one lung ventilation in thoracic surgery.
This one is a bit more nuanced. Volatiles inhibit HPV if used at concentrations greater than 1 MSE. This means they might worsen oxygenation during one lung surgery. TIVA, on the other hand, preserves HPV. So technically, TV should be better for oxygenation in thoracic cases, although modern studies show the clinical difference is small if you keep the gas concentration low.
Great. Section 12, Viva traps. We started with the definition trap. What else should I watch out for?
The half-life trap. If the examiner asks, why did the patient wake up so fast after a 4-hour Propofol infusion? What would? Do not say, because it has a short half-life. The correct high-scoring answer is because it has a short context-sensitive half-time for that duration. Using the wrong terminology marks you as a novice immediately.
And the TCI trap.
Confusing Marsh and Schnider. Or not knowing that TCI is just a mathematical estimation, it's not reality. If the patient is moving, don't just stare at the pump saying, but the target is high. You have to treat the patient, give a manual bolus. The model is a guide. The patient is the reality.
And safe answers regarding drug dosages.
Never give a fixed number. Don't say, I will give 100 milligrams of propofol. Always say, I will titrate the dose to clinical effect, or I will titrate the infusion to maintain a BIS between 40 and 60. Anesthesia is dynamic, and your answers should reflect that.
Section 13, diagrams and presentation. How do we visually sell this answer on the page?
If I am grading your paper, I want to see 4 things. 1, the 3-compartment model schematic, boxes and arrows. 2, the context-sensitive half-time graph. You have to be able to sketch the curves for fentanyl and remifentanil. 3, a simple schematic of the setup. 2 syringe pumps going into a 3-way connector with an anti-reflux valve going to the patient's cannula. And 4, a neat table comparing the pros and cons of TIVA versus inhalational anesthesia. If you have those 4 visual elements, you are already well on your way to passing.
Okay, finally, Section 14, Summary and Exam Conclusion. Let's just recap the key buzzwords for the learner to take away.
Hysteresis, biophase, context-sensitive decrement time, effect site targeting, Marsh versus Schnider, synergistic interaction, and neuroprotection via MEP preservation.
And if you had to dictate the perfect conclusion paragraph for our listener to essentially memorize for their exam paper.
Okay. Write this down, or at least the essence of it. Total intravenous anesthesia represents a sophisticated physiological approach to general anesthesia, offering independent control of hypnosis and analgesia. Quote, with the advent of target-controlled infusion systems and processed EEG monitoring, TIVA provides a superior recovery profile, enhanced hemodynamic stability, and significant environmental benefits for specific surgical subsets. However, its safe application is fundamentally reliant on the anesthesiologist's profound understanding of pharmacokinetic principles to mitigate the inherent risks of awareness and ensure a rapid, predictable emergence.
That sounds like a 20 out of 20 answer to me. It's perfect.
It covers the science, the technology, and the safety. That is what the examiners are looking for.
Before we sign off, a final thought for the road, something to chew on.
Well, think about where this is all going. We currently use open-loop TCI. We are the pilots. But closed-loop systems are already being tested in clinical trials. That's where the pump talks directly to the BIS monitor. The robot sedates the patient. So the question is, will the anesthesiologist of the future be a pilot? Or just a drone operator supervising the machine? Or will our role shift so we can focus purely on the complex physiology while the machine handles the simple task of hypnosis? It really raises an important question about the art versus the science of our specialty.
A little sci-fi to end our very intense study session. Thank you, senior faculty, for the masterclass. This was incredibly helpful.
My pleasure. Go and ace that exam.
And to you, the learner listening in, good luck on the Gujarat University exams. You've got this. Keep diving deep.